Good morning, good afternoon, good evening, wherever you may be, and welcome to the MCIRC workshop, Drug Permeability Best Practices for BCS-based Biowaivers. My name is James Polli, and I'm a faculty member at the University of Maryland. As you know, the Biopharmaceutical Classification System, or BCS, is a well-established scientific framework based on solubility and permeability of a drug substance, plus also considers dissolution of the drug product. It provides assurance that in vivo bioequivalence, based on extensive in vitro comparative characterizations, allows for the assessment of bioequivalence of products. And hence it provides a pathway to avoid unnecessary human studies. Most notably, just before the pandemic hit, BCS was finalized at the end of 2019 as the International Conference for Harmonization, ICH M9 guidance. And this, I think, essentially is a first major opportunity to talk about the M9 guidance. As perhaps I think many of you are here, since it probably is well recognized that one of the most difficult criterion to establish in the context of M9 or BCS in general is drug substance permeability being high. Some of the considerations are to rely on mass balance studies or absolute bioavailability, each of which can be, shall we say, difficult to ascertain, or extensive in vitro cell permeability data using properly validated systems. So overall, the aim of this day-long session is to discuss the industrial, academic, and regulatory experience in generating and evaluating permeability data in order to facilitate further implementation of the BCS around the world for efficient development of high-quality drug products. Just some things that you can obtain from the MCIRC website, since if you're like me, or even worse, folks on the west coast of the US, just getting off to the day, there is an agenda, there are biographies, and there's breakout information. Let me just say before showing those that within about 3 weeks, we will have speaker slides available on the MCIRC website, along with recordings. Recordings are being made from this point forward until 2 o'clock, as well as at the 4:05 p.m. closing remarks. So we're recording the so-called main workshop. We're not recording the breakout sessions. Let me just show you some documents in case you don't already have those. Okay, here's the agenda for the day. Just a quick look. Here we are starting things off. We have an introduction from a representative from the FDA about permeability. We have some industrial perspectives. After a short break, we have some additional perspectives from industry as well as industrial representatives. Most notably, we have a panel discussion from folks from all around the world. So I'll just reference that we do have a chat function. Please feel free to start using the chat function now to generate questions for the panel discussion. We also have a lecture on future outlook on permeability testing. And then perhaps also most notably, we have some breakout sessions. Hopefully you've already registered for 2 of these breakout sessions, so-called session 1, session 2, and session 3, with an eye at looking at in vitro and in silico intestinal permeability methods, potential excipient effects, as well as use of label and literature data to assess drug class permeability. Okay, we also have speaker bios. We'll be briefly introducing participants, lecturers, so we'll be relying on these bios. So please give some kind attention to the biographies. Finally, another document that's available. You certainly want to consult this between now and a few hours from now when our breakout sessions begin. Again, we have 3 breakout sessions. They each have objectives, and most notably, they also have about 4 sets of questions associated with each breakout session. And again, content will be available in about 3 weeks. All right, just a little bit more about the breakout sessions. Sessions 1, 2, and 3. Session 1, which concerns permeability methodology. The overall goal there is to identify permeability methods, assessment methods other than CAECO2, since M9 seems to focus on CAECO2, and how to validate sessions. Session 2, which concerns excipients, is to identify excipients that do not need to be either Q1 and or Q2 in various situations, including any limits on excipient amounts. And finally, session 3, regarding use of label and literature data. The goal is to identify label and literature data types that can serve as primary data to classify permeability as high and requirements to be met. With regard to WebEx logistics, this is an online workshop with breakout sessions, so a bit complicated. So we found ourselves, if you're listening to me, we are in the so-called main workshop. There's a URL that you've already found, and that's great. Please return to this URL at 4:05 for closing remarks. Again, please enter questions into the chat at any time for the panel discussion. If you're interested in participating in the breakout sessions, one of which is at 2 o'clock and one which is at 3 o'clock, you should have received an email, I think late last week, and those are separate URLs. So please refer to those separate URLs. If you have any questions, feel free to contact Ann Enninson. Okay. So this is a little more relevant for the breakout sessions. We'll remind you of this, but in the breakout sessions, there will be opportunity to discuss. So the way in which we'll do that is by raising hands. So we're not doing this now. This is more at the 2 p.m. and 3 p.m. breakout sessions. So at the bottom of the WebEx in the center, there's a react button, little smiley face, and you can tap raise hand in order to be recognized. Again, we won't use this now. We'll be using this at 2 o'clock and 3 o'clock. And then what you can do is reverse that by lowering your hand. Clicking on the, click on the react button and then lower hand after you've asked your question. Okay. So I think one reason we're here is because there's been some major harmonization through the ICH-M9 document. So first of all, congratulations to all of those who are involved in those activities. As a part of the Center for Research on Complex Generics, we recently underwent a survey. We asked questions of the industry, largely actually the generics industry, but I think one of these questions was relevant to today's topic and today's audience. And the finding is that there was substantial agreement on the importance of a harmonized international approach. So there's a lot of harmonization about the need for harmonization. With regard to this particular question, which had to do with complex generic product development, but I think it's very applicable to this topic of BCS. The question was in the form of a Likert scale, so there was 1 through 5. 4 and 5 are blue and green with regard to agree and strongly agree, and we see that about 96% of people either agreed or more preferably strongly agreed with regard to the need for harmonization. And I strongly suspect we're all here today because we sort of feel the same way about this particular topic of BCS. Okay, so here's just a brief history of BCS. I know many of you are experts at this, and I apologize in advance. When I put this slide together early this morning, I'm sure I left many things out. I can think of many things at the moment. So one item is, of course, the 1995 article by Amidon et al. And up there in the upper right is actually a recent picture of Dr. Amidon and myself. Dr. Gordon Amidon and his brother Greg actually recently retired from the University of Michigan. That was a picture taken from that October event just a couple months ago. The FDA issued a draft BCS guidance in 1999, which was then finalized a year later in the year 2000. A few years later, when Bennett published their BDDCS paper, the WHO guidelines were published a year later. EMA published a BE guidance in 2010. Most notably, it allowed for biowaivers for class 3 drugs. FDA sort of caught up with EMA in that regard several years later. And then just a couple years after that, just a couple years ago, ICH-M9 was published. And I apologize in advance for many things being left off. One thing that I can think of just sitting here now is I think maybe a 2002 paper from Lawrence Yu et al. With regard to BCS class 3 biowaivers. Okay. I guess one thing I would just like to remind the audience is that BCS has actually been around for quite a while, for over 20 years. So here's a graph from a paper that we published in 2000, which really underpinned what I understand was the first regulatory application of BCS, allowing for a biowaiver of a drug at Glaxo. Leo Lucasano, one of our co-authors here, worked at Glaxo, and we participated in basically a BCS biowaiver request. What's being shown here is a way to grow KCO2 cells through a reduced serum approach, 2% supplemented calf serum. That was sort of the scope of the academic paper. Built into that, though, was basically a request for a biowaiver of a Glaxo product, Glaxo drug. So the main point being, permeability certainly has been with us for a long time. In fact, I want to say there's probably more people that have conducted permeability studies in the past that actually do them today. So there's probably some lost knowledge in that regard. But hopefully we'll reinvigorate ourselves a little bit today. Okay. Just a little reminder, in particular, thank you to Donna, Tracy, and Althea at the FDA. MCERC is a FDA-sponsored center at the University of Maryland, Baltimore, along with the FDA, which is hosting this event. So thank you again. Also, much thanks for all of your attention and your participation. Thanks to the speakers, panelists, and breakout session moderators and scribes. Thanks also to the folks at the University of Maryland helping with the event today, Dana and Melissa, Yuli, and Victoria. Also, special thanks to Mihul Mehta and Paul So at the FDA with regard to all the support underpinning this event. Okay. All right, what I'd like to do is introduce our first speaker of the day, Utpal Munshi. Dr. Munshi is Division Director, acting at the Division of Bioequivalence 1 in the Office of Bioequivalence, Office of Generic Drugs. He's been in DB1 for many years, I think since 2007. He leads a team of scientists responsible for the assessment of bioequivalence section of ANDAs and other stakeholder submissions. Thank you very much, Utpal, for giving your lecture today, for kicking us off.
Good morning. My name is Utpal Munshi, and this morning I'll be providing a high-level overview of permeability as it relates to BCS-based biowaivers. Please note that this presentation reflects the views of the author and should not be construed to represent FDA's views or policies. Before I begin, I'll give you an outline of the presentation this morning. First, I'll talk about the scope of BCS biowaivers, then talk about the eligibility of BCS biowaivers, then describe the evidence needed to support BCS biowaivers, then at which point I'll shift to the main focus of today's workshop, which is permeability, and I'll give a brief overview of the different types of studies and evidence and the relevant considerations for these studies, specifically in vivo human pharmacokinetic studies, KCO2 cell methods, other methods, and also literature. Finally, I'll talk about excipients and permeability, and then I'll give a summary at the end of the presentation. So what is the scope of BCS biowaivers? They're used to substantiate the in vivo bioequivalence for comparison of products in the following situations. For example, comparison between products used during clinical development through commercialization, support post-approval changes, as well as for generic products who are comparing to the innovator product. Now, the ICH M9 BCS guideline provides some descriptions of situations where a product may or may not be eligible for a BCS biowaiver. So first, if we start here on the left and talk about instances where a biowaiver may be entertained, would be, first of all, the understanding that it's only for immediate release dosage forms that are designed to deliver drug to the systemic circulation. Fixed dose combination products may be eligible when all drug substances therein meet BCS or relevant BCS criteria. Prodrugs are eligible if absorbed as the prodrug. The test product containing different salts of the drug different salt of the drug substance as compared to the reference product may be eligible for a BCS-based biowaiver depending on the context. And what I mean by that is, of course, for generic drug products, here in the United States, in order to use the 505J pathway, the salt form of the API in the test product must be the same as that in the reference product. Finally, the test and reference products must be the same dosage form and strength. Now, crossing over to instances where a waiver may not apply, and this is not necessarily an exhaustive list, but examples would be for narrow therapeutic index drugs. They're not eligible for this biowaiver approach. Drug products with buccal or sublingual absorption. And also test products that contain a different ester, ether, isomer, mixture of isomers, complex, or derivative of the drug substance than the reference listed drug product. So what is the evidence needed for BCS-based biowaivers? So in this slide, I have a high-level overview of the evidence. For BCS Class 1 based biowaivers, we need a demonstration that the drug substance is highly permeable, that the drug substance is highly soluble, and that there's rapid and similar dissolution between test and reference products, as well as acceptable excipients. For BCS Class 3 based biowaivers, we would expect a demonstration that the drug substance is highly soluble, that there's very rapid dissolution for TNR, that there is also qualitatively the same and quantitatively similar formulations between test and reference. Regarding BCS Class 3 biowaivers, it's important to note that it's not necessary to demonstrate the permeability status of the API if pursuing a BCS Class 3 based biowaiver. However, excipient effects on permeability and absorption of the API should be considered. And we'll talk about that more later. So then delving into permeability aspect, there are various types of studies that could demonstrate the high permeability of the drug substance. Right? One is in vivo human pharmacokinetic studies, that is absolute bioavailability studies, mass balance studies. Second would be Keiko-2 cell studies. There are potentially other methods, for example, non-Keiko-2 cell lines in vivo, ex vivo, in situ, or in silico methods. But we'll talk about some of the considerations and limitations around those methods a bit later. And finally, applicants may choose to reference literature information, and we'll talk about that as well a little bit later. So for mass balance studies, what are the considerations? So first, high permeability can be concluded if there's at least 85% of the administered dose recovered in urine is unchanged drug, or is the sum of phase 1 oxidative and phase 2 conjugative metabolites. Metabolites in feces can be considered as reflective of parent drug absorption if oxidative or conjugative. Unchanged drug in feces can be considered as reflective of parent drug absorption if it can be demonstrated that the drug was absorbed and then excreted or secreted back into the GI tract, or that the drug is present due to an unstable metabolite. Reduced or hydrolyzed metabolites can be considered as reflective of parent drug absorption if it can be demonstrated that they were not formed prior to absorption. And finally, GI tract stability for the drug substance must be demonstrated if using a mass balance approach to demonstrate high permeability. Regarding KQ2 cell studies, what considerations do we have in this context? So for one, to use this method, we must understand that it's limited to drugs that are passively absorbed through this cell line. Passive transport should be demonstrated for the test compound in cells that express efflux transporters. Validation should be performed using model drugs to demonstrate that the experimental system can differentiate between drugs of differing permeability. Model drug permeability standards should be dosed with the test drug substance. The test drug is considered highly permeable when its permeability value is greater than or equal to the selected high permeability standard. And finally, the GI tract stability for the drug substance must be demonstrated if using a mass balance approach to demonstrate high permeability. How about other methods? So for example, some methods that we could theoretically think of would be some ex vivo methods, in situ or in silico methods. And it's important to note that at this time, regulatory agencies have only limited experience with the above methods. And so only in vivo or KQ2 data are considered for the permeability assessment at this time. However, as you'll see if you are participating in our breakout topic 1 later today, that there will be further discussion and exploration of the possible use of in vitro and in silico permeability methods. How about literature information? So theoretically, an applicant may use the information in the literature to support high permeability of the drug substance. However, we must understand that the information from the literature sources may not provide enough information or may be conducted in a manner inconsistent with being able to make a regulatory decision. In this regard, in breakout session 3 later today, there will be a discussion of this very topic of use of literature and labeling information to designate the permeability class. So let's shift a little bit to excipients and permeability, and what are the considerations about the excipients that we use in formulations when requesting BCS waivers. So in addition to demonstrating high permeability of the drug substance to support a BCS Class 1 waiver, it must be shown that excipient differences between the test and the reference formulations do not differentially affect absorption of the drug substance. Effects of excipient differences on intestinal permeability should be considered. For example, interactions of excipient with intestinal drug uptake transporters. For BCS-based biowaivers, excipients that affect absorption should be qualitatively the same and quantitatively similar between test and reference products. That is within plus minus 10% individually and cumulatively. And finally, excipient differences and resultant effects on absorption are more of a concern for BCS Class 3 biowaivers. With the exception of film coating and capsule shell components, all the excipients must be qualitatively the same and quantitatively similar between test and reference formulations. In this regard, there will be additional discussion on this topic and exploration in our breakout session 2, which will consider the excipient effects on permeability and when we would need to be concerned and should we be concerned. So finally, in summary, we can say that high permeability may be demonstrated using a number of different approaches, but only Keiko-2 and in vivo methods are considered at this time. Literature or label information could be used to substantiate high permeability in support of a BCS-based biowaiver, but there are caveats. And finally, permeability of the drug substance is only one aspect of the BCS-based biowaiver, and in this regard, we should emphasize that the effect of excipients on drug permeability and absorption should also be considered. I would like to thank my management and colleagues from FDA listed here, as well as for the organizers of this workshop for inviting me to give this presentation. Thank you, everybody, for your attention.
Thank you, Utpal.